I'll speak. So I want to share my techniques and pearls, what I will learn over the 24 years of my small experience in the cataract surgery. So as we all know, posterior capsule is so first part is the capsular axis. So usually try I usually try capsular axis size between 5 to 6 millimeter. As these cases, posterior polar cataract are usually soft cataracts, and idea behind keeping axis size between 5 to 6 millimeter is when, in case of PCR, you can have fair margin of rim of entry capsule, so you can implant sulcal IOL. So this is around 5 or 6 millimeter capsular axis, and this is the posterior capsule. Then next important is hydro procedures. It may be hydrodissection or hydrodelineation. So this is the most important part for phaco or SICS. When you just separate your nucleus from the cortex or your epicortex from the capsule, then things are very easy and complications are very less. So in this case, I do hydrodissection in all my posterior polar cataracts along with the hydrodelineation. So then nuclear flotation, prolapse and delivery. This is most important part. You can see this is a you can the term as a manual femto, but it's better than the femto. As your nucleus is already out from the danger zone. When you are doing SICS, then you can take it out with the any method, or when you are doing the phaco, then repose it back in the bag. Sir, please. So this is nucleus is taken out. Now this is one of other procedure. I am doing hydro now irrigation aspiration. Again, this is a very important part of any cataract surgery, and most of complications happens here in the posterior capsule. So just see this. This is a case, and I have idea this is going to be other way around. So I use IEA and see now there is something wrong here. So don't worry here. See, this is badly struck, and I keep on aspirating the cortical matter. But here is a one trick. After a few seconds, I this is going to be behind. So what I did, I leveraged with this irrigation port. See here, this port is going behind the epicortex, and there is no practically no chance of going back. So I've taken out all the plate. As you know, there's already PCR. So this now anterior vitrectomy, very important part. I do with low highest cutting rate of a machine, uh, about a moderate section, and be in the center. And this is not related to this case. This is another case where nucleus had dropped during the phaco. So I want to see that clear as much as vitreous you can do. Don't be panic. I usually don't use Tramslon because my macros is quite good and visible to me all fat. But sometime when I require, I I can use Tramslon also. It's a good uh, tool and technique. So idea is clear the vitreous as much as you can do. Now I use always PMM lenses in the sulcus because the PMM lenses are very stable, and they are when they are implanted in the sulcus, they are fixed like anything. So, and there is what I've seen over the 24 years of my experience, that these are lenses are no less uveitis or practically no uveitis as compared to the foldable lenses, three-piece folded lenses. So, for the sulcus implantation, it's a trick. Basically, you have to be your leading haptic should land in the sulcus first, then rotate in the same plane. Now, retro eye hole cleanup is very important. What we do many times that we leave the vitreous and visco behind the lens. So we should never do this. We should do thorough cleanup anteriorly or posteriorly. This is I'm going. I just I'm doing behind the lens, and irrigation port is just in front of lens. My cutter in the center, and I have no hurry. Then, when there's a nucleus drop, I always suture and suture properly, because your vitreoretinal colleague need a leak-proof, tight, uh, tight like entry chamber and all these things. So I usually 2 or 3 sutures, buried suture, and this is not case the first case, but in this case also it was next day vision was the 612 after a drop nucleus drop surgery and this. So thank you very much.
Thank you so much for your nice presentation. You have managed the things. But anyway, my question, why you have preferred SICS over the FICO in the pushes polar cataract? Any advantage?
Yeah, because in this case, if there is a rent, then all the compromise happens. So I know this space is going to be this going to have the PCR. So SICS is all the advantage of the fake, or what we call the femto. So
But
this is just to give the safety to the patient. I prefer I prefer not to give patient like a drop, a nucleus drop, or something like some any other iatrogenic complications.
you know, the basic principle of managing the pusher polar cataract, you have to maintain the chamber throughout the surgery. This is very important part. So as I think the FICO is much better than the
No, no,
other
no. You
size.
are right. No, no. You are wrong, sir. In this way, just I'm
That
explain.
is a first.
I'm explaining you why you are wrong, because the SICS is low pressure surgery, and FACO is a high pressure surgery. So when there is a thing which is going to drop your nucleus, so this is low parameter surgery, and why you want this is there's nothing like positive pressure on all those. So
Anyway, anyway, this
yeah.
is the maybe the surgeon preferences, but as I feel, you know, in the FECO also, the slow maker FECO facility is there. So always, you know, if you maintain the chamber, this you have already in this case by doing the SICS. What happens once the chamber is shallow? Any moment the VTS will comes and the
No,
posterior
no, no,
polar
no,
lens
no.
will action
Because
completely.
no, 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 no. Just I'm not. I'm not.
Yeah.
So,
Yeah.
no, 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 no,
So yeah. So you
I
so you can include the infusion from the side.
let me explain. If you raise this point, let me explain, and you should give me the fair chance to explain this, because what is happening in this cataract also, we have taken out nucleus without. There is a thick apinuclear plate adhering to the capsule. So that until that up to that place, there is no chance of vitreous will come out. Okay. Then the second part I've used the IA, bimanual IA, as you used in the FACO. So this is misconception that maintain all that. This is one misconception also, that we should not do the hydrodissections.
okay.
So
Sudhir, one
so
question.
yeah.
Uh, I saw the management, everything.
How many cases have you converted a PPC into a PCCC and put an IOL in the bag using SICS?
Pardon?
Out of all the cases PPCs that you have done,
Yeah.
how many cases have you been able to convert the posterior polar deficit into a PCCC and put an IOL in the back? Posterior
Yeah,
CCC.
yeah, I do, but I don't have exact data to tell you. But I have in this next be presentation, I'm going to in the that I have different cases also. This type of all these cases, I'm documented video proofs. So I use my idea is when rent is small, about 2-3 millimeter, then I use the IOL in the bag. When lens is more than 3-4 millimeter and bag is not stable, then I use the sulcus.
Okay, thank you, Dr. Sudhir. Would like to just add few points.
No, no, no.
Yeah, one more point I just wanted to add is
Yeah,
not all PPCs will have a posterocapsular rent. So if you had done an anti-segment OCT, if you have seen a rent, even then we have methods to manage with a phaco also,
no,
sir.
no. That is a one modality to phaco is a modality to manage the nucleus only. In SICS, you have the also the you can minimize the 0.75 millimeter or 0.75 diopter of astigmatism. So phaco is just a modality to manage the nucleus, nothing else. So this is our mindset because basically when we do, but in as I case, my previous speaker, I forget the name, but he have used the you used for the toric and those are all the compromising things and all that. So I don't want my patient to be compromised. My I want the patient to give the hysterectomy the next day. So that is the idea. And as I give scientifically proven all these things. Okay, thank you.
Thank you very much, Dr. Sudhir.
Yeah. Yeah, yeah. Yeah, again, this was deliberate. There's so many things which are not in, we do not put in the publications. Idea is to hydrate bitters is not a problem. When you are going to do the vitrectomy, so my vitrector was ready. So this was deliberate not to sunk in that piece of cortex in the vitreous. So in what we do in the three-fourth part planar vitrectomy, what we do? We deliberately hydrate the vitreous, then do the vitrectomy. So all these things are the misconceptions which are not published. Okay, so
Thank
Is
thank
Dr. Bharti Kashyap. Thank you,